It is my job to introduce the man who needs no introduction, but I was more than happy to do it. Um, Dr. John Whyte is the founding director of the Moss Rehabilitation Research Institute, now the Jefferson Moss Rehabilitation Research Institute, and current faculty emeritus. He is a physiatrist holding an MD and a PhD in cognitive psychology, which is, I think, a rare MD PhD combo, too rare. Um, and he has made many, many contributions to traumatic brain injury research, including groundbreaking work on the rehabilitation of disorders of consciousness, which has in part led to the founding and direction of the clinical responsiveness program here at Moss Rehab. But his another major contribution to rehabilitation research and care, which he will be talking about today, is the methodological challenges around the specification of rehabilitation treatments. So, without further ado, here's John Whyte to talk about the rehabilitation treatment specification system.
Thank you, Amanda. And this is a topic that I've spoken about before and that I will speak about again. So let me just, to help me a little bit, how many people are kind of not really familiar with the rehabilitation treatment specification system at all? Okay, how many people have heard of it and know a little, but not too much? Okay, all right. And the rest of you know more. So this is one of my challenges that in order to sort of understand the subsequent developments in the field, we have to go back, and someday everyone will know about the RTSS. And so I will skip the introduction, but I'm going to sort of try to navigate the middle ground here so that everybody is on top of what's going on. And of course, we are grateful to Nancy and Marc Shrier for supporting this series. Here's the information about where you can get your credit. I just recently decided to stop getting CME and to let my license lapse, so I no longer have to write down CME credit numbers. It's very exciting. And our people who have nothing to disclose, and then our learning objectives for today. What the problem is that the RTSS was intended to solve, what it's solved so far, and what it still needs to solve. So what it is intended to solve is this problem that's been talked about for decades in rehabilitation, the black box of rehabilitation, where we've developed increasingly sophisticated ways of characterizing the patients we treat, their social attributes, their demographics, their clinical severity, blah, blah, blah. We have developed increasingly rigorous measures of various kinds of outcomes that might occur as a result of the rehabilitation process. But the thing that we do, the thing that we are supposedly responsible for, the treatment in the middle, we don't have any useful way of talking about it. So we talk about, inpatient rehabilitation, occupational therapy, gait training, cognitive rehabilitation, all of which are nice labels that tell you what somebody's concerned about, but very little about what they are actually doing in the way of treatment ingredients. I would make the analogy, if we were talking about drug treatment, it would be like having conversations about whether big blue pills are better than little white pills. Not very productive. So we would argue that this is a key problem for research practice and education in rehabilitation. We can't tell whether two treatments are the same or different because we don't know what that means. So we can't compare them, or we can't meaningfully compare them. We can't replicate or disseminate effective treatments because what parts of those treatments need to be disseminated in order to remain effective. And we lack a common language to describe treatment across clinicians and disciplines. OTs do a lot of things similarly to PTs, but they have different words for the same things, et cetera, et cetera. And sort of in the current age, a sort of a magnification of that is how can we learn from electronic medical records if the words and terms in those records don't map on reliably to any particular thing. So this is the landscape that we're trying to address with the RTSS. Now, before I get into more detail, let me just quickly take you on a whirlwind tour through two broad classes of theory that are relevant to rehabilitation research and practice: enablement theory and treatment theory. So enablement theory is really talking about the relationships among different kinds of functions in a ICF type functional landscape. Now, this is undoubtedly a ridiculously simplistic diagram, but what it's pointing out is that we have different levels of functional attributes from body structure, body function, activity, participation, and that importantly, that something like employment is going to be determined by many, many things below it. So if you were to do an intervention on language comprehension across a bunch of people, you couldn't reliably predict that they're all going to improve their employment because some of them are unemployed because they don't have any work skills. Some of them are unemployed because they have inappropriate social behavior. Some of them are unemployed because they have language comprehension problems, but maybe even those people have other things too. So the issue that enablement theory helps us understand is what does it take to be a public speaker? What does it take to drive safely? And then analyzing the strengths and weaknesses that contribute to an individual person's ability or disability. In contrast, treatment theory is about changing things in that landscape. Treatment theories have three parts: the ingredients, the active ingredients in this case, the target, the functional thing that those active ingredients are directly changing, and then some theory or hypothesis about the mechanism by which those ingredients lead to that change. Now, importantly, we need to think of these two sets of theories together. Enablement theory helps us understand individual differences in a given function and predicts the downstream impacts. If I treat your language comprehension, will I get improvement in work or won't I? It helps us answer those kinds of questions, but it doesn't give us any tools for changing anything. It says, if you change this, this will also change. But how to change it? No idea. Treatment theory is exactly the opposite. Gives us effective tools for changing a specific thing, but it says nothing about downstream ramifications of changing that thing. If you change language, I have no idea what impact that might have anywhere else, but I do know how to change language, let's say. Okay. Now, considering those two bodies of theory, as we developed the RTSS, we made important strategic decisions. First was that treatment should be defined with respect to their known or hypothesized active ingredients. We don't want labels that tell us who's doing the treating or where they're doing it or why they're doing it. We want labels that map onto the actual active ingredients. And those are the ingredients responsible for changing the target, that very direct thing that the treatment changes, not the downstream things. And therefore, we should hold a treatment responsible for changes in the target. We shouldn't hold it responsible for downstream changes. It's not the fault of my language comprehension treatment that you didn't go back to work if you have social problems. I didn't address those social problems. I shouldn't say I have an ineffective treatment for your language because it didn't fix your social skills. Second important point, almost all rehabilitation treatments are what we refer to as complex treatments, meaning that they are treating, it's a bundle of ingredients that are treating a set of interrelated targets for a larger goal. So, let's say you were wanted to treat depression. You might have the medication that's designed to change mood. You might have education about the side effects of the medication that's designed to improve compliance with the medication. You might have family education that's designed to increase social support for the person with depression taking the medication, et cetera, et cetera. So they're all related to trying to give care to this person with depression, but they have different specific purposes that you've combined together into this aggregate protocol. Well, if we want to understand the active ingredients, we have to divide that treatment into its pieces and link the active ingredients with the piece that it's intending to change. So that's the second point. We need to break down our complex treatment into its parts. Thirdly, many treatments are selected to achieve a distal goal, which we call an aim, but the probability of achieving that goal is, as I mentioned, predicted by enablement theory, not by treatment theory. So we shouldn't use that to judge treatment efficacy. If we need to think about downstream effects, we need to think about who are the people likely to experience a given downstream effect from a treatment, and or what other treatments would be needed so that this or many people could achieve a downstream. So maybe I need to do language therapy and social skills training in order to impact employment, hypothetically. Okay, now we're almost through the introduction for those of you who are unfamiliar. When I said that we need to break down complex treatments into their parts, we further argue that those parts exist in three categories. That all rehabilitation treatment components, that's one of the parts of a complex treatment, all treatment components fall into one of these three groups. There are organ functions treatments, things like medications, electrical stimulation, exercise, stretching. These make changes in organs or organ systems. We can also do prosthetic replacement of organs and organ systems. And their mechanisms depend on the specific organ, but they tend to be physical kinds of mechanisms, physiologic, biologic, etc. And so the key ingredients are typically some kind of physical stimulus or energy. Second category, skills and habits. These are the zillions of behavioral skills, mental and physical, from very simple, like to reach for something, to complex, like public speaking. The key unifying ingredient here is that they are all things that you improve through practice. The way to get better at reaching is to do more reaching, etc. And then the third category, representations, short for mental representations, is referring to the contents of the mind, knowledge, attitudes, beliefs, motivations. And those typically are changed or altered by either the delivery of new information or the request to re-examine and reorganize information that you have already acquired, things like education and counseling and so on. So, feel free to find something that doesn't fit into one of these categories, but we have argued that these are comprehensive categories for everything that goes on in rehabilitation. Now, one final point, volition. The vast majority of rehabilitation treatments are not things we do to people, but things we guide people to do for themselves. And those we refer to as volitional treatments, meaning that they can't happen if the patient is unwilling or unable to participate. So for this kind of treatment, we have two things that need to happen. One, I have to have delivered the ingredients that get you to do the treatment correctly. And then I have to make sure that the thing that I asked you to do has active ingredients that really achieve the target. So we have two bundles of ingredients in every volitional treatment. The ingredients that get you to do the treatment, those are called volition ingredients, and the target is performance of the treatment activity as directed. And then we have whatever ingredients you designed for that treatment activity, and they have the target of improved strength, improved skill, improved whatever. In order to figure out what ingredients people need to make sure they do the treatment, we refer to a model of health-related behavior called COM-B, which says that if you want somebody to engage in a given health-related behavior, they need to have the mental and physical capability. They need to understand what they need to do and know how to do it. And if they don't, you better tell them or instruct them. They need to have the opportunity, which if you're in a supervised therapy situation, it's this half hour in this room right now, no problem. But if you're telling them to do homework, when are you going to do it? Is there time? Is there space? Is there opportunity? You might have to plan that. And thirdly, motivation. The person has to want to do it. And so we have to find out whether they are motivated. We have to deliver information about why they might be motivated, and so on and so forth. And of course, the more dreadful the treatment is, the more motivated they have to be. So you have to think about is the patient more passive and less likely to be motivated, and is the treatment one which requires a whole lot of motivation? Okay, all of that process is now summarized in the Manual for Rehabilitation Treatment Specification, now in its second edition, and which can be downloaded from SCRM for free. And with what we've developed so far, here's what you could do. A researcher can describe their treatment in transparent terms that do allow the active ingredients to be replicated by other clinicians or researchers. So that's a step forward. A researcher can design logical comparison treatments that differ in theoretically informative ways. So imagine that you have this new treatment and you decide to compare it to standard of care. Well, what if standard of care has 80% of the ingredients that you designed in your new treatment? That's a dumb study, right? So it allows you to ask, if I'm contemplating this as my comparison, how much overlap in ingredients is there, and is that a good comparison? And what's it really controlling for, and what's it not controlling for? The system allows explicit description of treatment theories instead of just saying, I'm doing this because I learned how. I'm doing this because here's what I think its effect will be on the target, and here's why. And now somebody else can say, that doesn't make any sense. I disagree. This is my theory instead. So we can actually have theoretical conversations, and then we can do empirical tests of our theoretical perspectives, i.e., clinical trials that are nested within a theoretical framework. Um, and of course, if we talk about what the active ingredients are, that facilitates clinical education and supervision. I can make sure you're delivering the active ingredients and not a bunch of filler. The distinction between treatment enablement theory helps, and between targets, volition targets, and aims allows people to disentangle the reasons why treatment might fail and to analyze sources of failure more analytically. But there are things that the system does not yet allow us to do. We can't easily aggregate or meta-analyze data across studies because we don't know which treatments belong to the same category. Here's the problem. Researcher A clearly specifies their treatment in their words. Researcher B clearly specifies their treatment in their words. The words aren't identical. Are they synonyms or are they different? Right? So until we come down to words that we agree are the same or different, it still remains hard to know whether I should group these 6 studies together in one category. They're all using different words, and I'm not quite sure. We want to be able to conduct comparative effectiveness research, but we often have treatments that are just a big mishmash of ingredients with somebody's name on them. And now we're going to compare them to another mishmash with somebody else's name on them. And we're going to compare Smith to Jones without ever really knowing what ingredients we're comparing to each other. Doesn't sound very helpful. We'd like to be able to exploit EMR learning health system, but we've got to have words that have more solid meanings to do that. And if we want to have cross-disciplinary discussions of theories, we have to be using the same language in those discussions. So you've heard all the things that I said we want to still be able to do. There's this undercurrent of language in there because we argue that the next frontier involves developing an RTSS-based shared communication system. So if 2 treatments right now differ in their targets or their active ingredients, we don't know whether that's different labels for the same constructs or meaningfully different constructs. And so the potential solution is to arrive at a finite set of terms, unique set of targets that are well-defined, a unique set of ingredients that are well-defined. And now every clinician has to say, I'm treating this target or this target or this target. You can't make up a new word. And similarly for ingredients. So now I'm going to kind of take you away from the background, which I hope, despite my rapid pace, people have grasped, and go into some of the more recent developments in RTSS application. So I think in a previous talk, I told you a little bit about this one area of work, which I think shows the promise of the method. Probably you are not fascinated with voice disorders. I'm not fascinated with voice disorders, but it is where it's sort of like the model system for developing this work, and it's been incredibly productive. So muscle tension dysphonia, basically a hoarse voice, is a common problem treated by voice therapists. There are, I think, 8 different named protocols that have been shown to be better than nothing, with people's names on them. And there have been several comparative effectiveness studies comparing Smith to Jones that find them equivalent. But nobody knows what's equivalent to what because they're just people's names. Okay. Um, so we don't know how similar or different these protocols are, which seems kind of like a good question to ask before you start comparing them empirically. Um, Now, this group of voice researchers uh, did work with Delphi panel and a bunch of background work to arrive at a finite set of operationally defined target words. These are the things we treat. And ingredient terms, these are the ingredients we treat them with. And there were some probe questions that helped them figure out what does it mean to say these two things are different versus the same, so that the framework was clear. And so now within this small domain of voice therapy, hypothetically, we can ask every clinician to identify from this set of targets and from this set of ingredients what they're doing. Um, they then took the 9 of these named treatment protocols, and in what was not only a scientific feat, but a political feat, they got the original developers to collaboratively re-specify them in standardized RTSS terms. So now, for the first time, these 9 protocols could be laid side by side and say, they all have this. This one has this, and none of the others do, et cetera, et cetera. And not surprisingly, that effort is still ongoing, but not surprisingly, there was quite a lot of shared ingredients. There were some unique differences, but they would lead to specific predictions about different outcomes, not some global difference of this one's effective and that one's not effective. They also were able to use these to code videotape records of actual therapy sessions and get high reliability about what ingredients were being delivered, what targets were being treated. And in that initial pilot data, they were able to show that there was more similarity in the ingredients used by a given therapist across multiple patients than across therapists. So therapists do seem to have meaningfully different practice styles with different ratios of ingredients that paves the way for asking, does that make any difference in the types of outcomes? Now, that's been done for this tiny little area of voice therapy. If we wanted to reap those kind of benefits, we'd have to do that in every treatment area. We'd have to come up with operationalized targets and ingredients. And that's a big job. But Jared Van Stan, one of the people who led the voice therapy work, currently has an R01 under review to propose to do exactly the same kind of Delphi target and ingredient development in gait training, upper extremity reaching therapy, and ADL training. So not going to cover the field, but it's going to extend the work. Obviously, if we thought it was feasible to do this across rehabilitation, we would have to have some method of coordinating this, which we don't yet have. Who's going to develop the list of targets for this? Who's going to develop for that? And if I don't agree with them, or I think one's missing, who do I contact, et cetera? And we don't expect any of these lists to be static, because we're going to invent new things to treat, and we're going to invent new ingredients to treat them with. So there will need to be some sort of ongoing way to modify and adjudicate this kind of library, if such were to exist. But then I want to just finish by okay. I want to spend the last minutes of the talk telling you about some additional areas of impact that have emerged since that initial area and that I think are quite exciting. So in clinical education, we've seen a real uptake of RTSS, and I think multiple faculty are finding it an extremely valuable framework for educating, starting rehabilitation therapy students of all disciplines. So a bunch of institutions that are listed have already incorporated RTS specification concepts into their curriculum, and many rehabilitation science programs now have interprofessional education, so they have a fair amount of coursework that's not for a specific discipline, but for everybody, and so this becomes a very useful framework for that. They've what we hear in general is that people are using it in sort of graded specificity as the students mature. So in the earliest thing, it's just the notions of sort of targets and ingredients and mechanisms and starting to talk about what they might be and so on. And as they progress, they get into more detailed specification of treatments, more discussion of volition and so on and so forth. But it's been, as I said, a useful framework. Lynn Turkstra, who has been a visiting faculty member here, is co-author of a cognitive rehabilitation textbook called Transforming Cognitive Rehab with McKay Solberg and somebody Hamilton, whose first name I can't remember. And they incorporate RTSS as one of the main frameworks for treatment planning. One of the issues within cognitive rehab is that it's easy to think that it's rehabilitating cognition, but when you pull back the curtain, most of it is rehabilitating much more specific things, helping you adjust to your cognitive losses, helping you shop for groceries despite the fact that you have a memory impairment. So the targets are not fix your cognition. The targets are who knows what they are, but it'd be nice if we specify them correctly rather than keep talking vaguely about cognition. There's preliminary evidence to suggest that this kind of RTSS-based training facilitates clinical reasoning. We have a couple of colleagues who work in the UK system in physical rehab who've used this for frontline clinician training. One of the methodological challenges in assessing, we believe that it should improve clinical reasoning because it gives you very structured guidance. But one of the problems is that how do we currently measure the quality of your clinical reasoning? Mostly we do it by asking you how confident you feel about your clinical reasoning. And so if I just gave you a big course where I told you that this should improve your clinical reasoning, and now I say, how's your clinical reasoning? Oh, I feel that it's improved. It doesn't feel like very persuasive evidence. But we don't have any rigorously tested way of objectively assessing how good your clinical reasoning is. So it's a bit of a dilemma in terms of proving that impact. In research and research reporting, also a lot of interesting progress. There's an organization called Cochrane Rehab in Europe that is, if you're familiar with the Cochrane Collaborative, that tries to pull together research in a given area and kind of do a big meta-analysis and say, here's what we know about the area. A subgroup was created to try to do that in rehabilitation, which has its own set of challenges. So that's Cochrane Rehab. One of some of the tasks that Cochrane Rehab took on, one was to define the domain of rehabilitation, because if we're going to say, if you're doing something in rehabilitation, you should do X, we have to know when you are and when you aren't doing something in rehabilitation. And that itself is a little bit challenging. When does surgery leave off and rehabilitation begin, et cetera. But they did produce a consensus-based definition of rehabilitation such that if you're doing that, you should fall under certain recommendations. And then most recently, just published in evidence-based medicine, a new reporting guideline called Guide Rehab. It is intended to be the way you should report treatments in any rehabilitation treatment study. And by treatments, this is another thing that was a step forward. Here's how you should report the experimental treatment. That, in some sense, is the easiest because you're in control of that and you ought to know what's in it. But how do you report the comparison condition if it's not something you personally designed? You won't know as much about it. You won't have the same level of detail. So essentially, it asks you for the comparison treatment to tell us in as much detail as you can, but paying particular attention to ingredients that might overlap with the active ingredients that you have already defined well. So if you can't tell us about everything, pay attention to whether they're getting the same treatment in that group too, right? And then thirdly, one that I don't think hardly any reporting guidelines address is the notion of background treatment. So most rehabilitation studies involve doing something additional to people who are already in some kind of rehabilitation system. So we have to think about the ingredients that both the experimental group and the comparison group are getting on top of those things that could block the effects of the experimental treatment, augment the effects of the experimental treatment, or in some other way distort the findings. All of those treatment descriptions are structured around RTSS concepts. Identify specific targets, link specific ingredients to those specific targets, etc. Now, one of the worries or challenges facing journal editors in imposing a new reporting guideline is, of course, there's pushback from all the people who don't really want more demands placed on them. And in particular, they don't understand these demands and they'd have to learn about them. We're currently in discussions with journals about how they want to roll it out. There are a couple editorials being published right away about why it would be good. I think that some journals are going to start doing it on a pilot basis. And we're also exploring the possibility of having a group of RTSS expert article reviewers working in the editorial system of these journals who will provide specific feedback on treatment articles about how you could more closely meet the descriptive requirements of the guide rehab. And we hope that through that sort of consultation process, in addition to making the article clearer, that provides training to that writer so that they're now beginning to think in those terms around subsequent studies, around replications, and so on and so forth. And so multiple researchers we know have already used the RTSS to specify their own experimental interventions. A number of articles have used the RTS as to structure reviews or meta-analyses and figure out what categories should be put together. And an interesting publication looking at the reasons for null outcomes in a clinical trial by analyzing overlap in ingredients between the experimental and the comparison condition. And a group of folks who are active in the ACRM are working on a scoping review that's going to look at all of the published uses of RTSS along these lines. Maybe one of the most exciting things for me is an EMR design pilot being conducted at Shirley Ryan Ability Lab, formerly Rehab Institute of Chicago. So I mentioned that currently the electronic medical record is close to useless in rehabilitation for doing research because the things that if you want to go past hours of this and hours of that, you're kind of stuck. And so we would love if somehow the RTSS could infuse its way into the documentation system so that we really knew what people were treating and we really knew what they were using to treat them. That's not at all the way documentation currently, it's really focused more toward billing. I spent a lot of time doing complicated things with a needy patient, so pay me. But you can also imagine what would be involved in overhauling the EMR. And my first thought in, even contemplating it was not only how would I ever get the IT department to, go along, but clinicians will throw a fit and flip out. And, because it's a lot easier to say, I did a lot of hard stuff today and it was nice. However, here's what's happened at Shirley Ryan. They got 3 pilots in 3 very specific areas: dysphagia, swallowing disorders, gait training, and ADL addressing ADL stuff. And they have an OT person, a PT person, and a SLP person who work in their education department, sort of leading these efforts. So the lead up to this was enormously complicated and demanding and not something that most institutions are going to go through. So thank goodness for Shirley Ryan, because they pulled all the research literature about treatment in this area so that they could sort of get a preliminary list of possible targets and ingredients. They pulled together groups of clinicians to have discussions. They had to educate them enough on the RTSS in order to have the discussions. And then they had the discussions about what targets and are this the same as that. And they sort of, they weren't as formal as Jared in the sort of Delphi process, but they basically, the goal was similar, to arrive at a finite set of targets and ingredients for each of these areas. The one that's farthest along is the swallowing. That they did these in sequence. The swallowing one, they've completed the identification of targets and ingredients, and they've started the documentation of all swallowing therapy in that manner. And what's really incredible about it is that well, first of all, it was possible. They were able to document this way. Clinicians were able to learn how to do it. They actually found out that the amount of time it takes to document is similar, or maybe even a little bit less. So that's a good thing. And the other thing that they were able to do now is take all of the cases that were being treated across, I think, 11 clinics around Chicago, and look at the targets that were selected and the ingredients that were selected, and essentially ask how evidence-based was the practice in each of these places. And they found that I think 9 of the clinics had very similar aggregate statistics, not perfect, but 80% of the sessions seemed to be in line with the evidence-based linkages. And then 2 clinics that were way outliers, much lower. Now, they don't know yet why, but you can see where this is going, right? Now we can go to those clinics, we can have discussions with them about what their logic is. Is there something different about the patients, or did they get bad training and we just need to retrain them, et cetera? But we can begin to look at practice differences in meaningful ways with these data. Interestingly, they started off with just doing the documentation about the treatment sessions, but the goals for the patient were listed in the old system. Pretty soon, the clinicians started banging on the door and saying, can't we restructure the goal section, because we find it much more logical to set our goals in the same framework. So they went back to the IT department and said, can we make this project a little bigger? And they changed the goal section as well. And now clinicians are saying, I don't like having to document other things in this old way. How soon can we transform the whole EMR so that this is the way we're documenting everything? So frankly, this was like so much better than I thought, because I thought it was going to be really convincing clinicians that the pain that we're causing you is worth it for the outcome. But apparently we're not even causing you much pain. So that makes things much easier. So it still doesn't answer the question. We're going to have a Shirley Ryan designed EMR. Is the whole world going to adopt Shirley Ryan's EMR, or how do we develop a general structure and a way of moderating that structure over time as things change? So I'm going to wrap it up, and I'd be happy to discuss future options. But just to summarize what's happened with the RTSS, the manual and the original set of articles were published in 2019. So that's 6 or 7 years ago. We hear tons and tons about the slow uptake of research outcomes. And I think this is actually an exciting example of a pretty fast one. To see in 6 or 7 years to go from published articles to pretty widespread attempts at implementation in a lot of different menus. We've had over 1,600 manuals downloaded internationally, 57 journal articles where RTSS is a key word, and of course more where it's a minor detail. As I mentioned, preliminary evidence of positive impact in education, clinical practice, and research. I hope I've convinced you that if we could get to the point of RTSS as a shared communication system, it would further amplify the benefits that have already accrued. And there are a lot of pilot projects who are pursuing different avenues of RTSS implementation. And I guess the last thing to think about maybe is if we do envision a realistic rollout where this could be a set of shared terminology, uh, who would be the sort of overseeing entities? One possibility is professional societies. Of course, then we'd have to decide that OTs own ADLs and speech pathologists own swallowing. Maybe we could cope with that, but there will be some contentious areas in between, like cognition, probably. So, anyway, there are a lot of practical problems to solve, but I think we have enough evidence that it's worth trying to solve those practical problems. So I will stop there. I'm happy to discuss or answer questions.